Yeah.
All right, so I guess I'll get started. I am Dr. Jaclyn Bertorelli. I am the first year surgical resident at Southwest Vet Surgical Service. As far as where we're located, there's 4 locations total. There's one down in Tucson, and then there's kind of the downtown Gilbert area, up in Scottsdale, a little bit north of the 101 in Scottsdale Road, and then Peoria, where our West Valley location is off of like the 101 and Olive. So today we'll just talk about really the basics of anesthesia. I try to touch upon a little bit of everything as far as setting up like machine, and then some drugs, and then getting into just monitoring. So we'll kind of start with just taking the patient in right in the morning when they are getting dropped off for surgery. So main things to think about is just physical exam basics. So do they have a heart murmur? And that could change like the medications that we use, the fluid rate that we use, just for to make sure that their heart's safe, and then do their lungs sound clear for the inhalant, and then are they hydrated, just looking at the overall patient status, should they be started on fluids before, any pre-existing conditions like endocrine disease, so are they diabetic, do we have to be concerned for insulin, if they got insulin, Cushing's, Addison's, things that can that might affect anesthesia. Do they have any recent vomiting or diarrhea that could maybe be severe enough where we consider holding off on surgery, or is it more of an emergency type of surgery? And then skin issues, so just looking especially like spays and neuters in these puppies, sometimes they can be a little bit gross in their skin, so just making sure that where the surgical site's going to be, that looks clean, and any way to reduce risk of surgical site infection, and then even same thing with like the IV catheter leg, just making sure anywhere where we're poking is clean, and then thinking about the surgery itself, so if it's a mass removal, if it's on the leg, as far as IV access, would it be easier to do back leg if surgery is going to be more at the front, whatever is going to be easier to access the IV, and then are they fasted? We like dogs to be fasted usually from midnight the night before, just to make sure their stomach's empty, reduce risk of regurg and vomiting, but that can also be a downside for smaller breeds or young dogs, just because they can, if they're fasted for too long, they can become hypoglycemic. So just kind of looking at the patient as a whole before we kind of jump into surgery. And then the anesthesia machine, so these are the kind of very basics and the main things to think about. So are they going to be set up on a non-rebreather based off the size? Usually we go based off less than or greater than 5 kilograms, so non-rebreather versus a rebreather. Make sure that machine's set up each day, kind of each morning. Whoever's using that, just check it, even though we used it yesterday, make sure nothing got unplugged. Check the soda line, make sure that's not changed so it's not purple. And then your ISO should be filled each time before anesthesia or after from the last surgery, so just make sure that's at the fill line, because you don't want to run out of ISO in the middle of surgery. And then hooking the machine up, so hooking oxygen, and then the waist, and making sure that the pop-off valve is open. That's really the most important thing, just because you need to make sure that they're able to get oxygen and blow oxygen off. And then picking out the bag size for ventilating, so it typically go based off of the weight in kgs times 60. So if you have a 15 kg dog, it'll be about 900 mils, so I would usually reach for like a 1 liter bag. And then after you set up your machine, make sure you leak test it. So you want to make sure that the bag doesn't have any leaks. If it does, troubleshoot that, switch the bag out if there's any holes in it. And then have everything set up before you start knocking the patient down. So pick out ET tube sizes that you think would fit the animal. Brachiocephalic breeds, you're going to go lower. But still grab about 2 to 3 sizes just in case if you're struggling and it's tighter than you thought it would be, you have the next size down. Lubricate the cuff, it creates a tighter seal, and it's a bit safer for the trachea. And then make sure that you leak test after you intubate them. Make sure that there's no leakage of ISO. If there is, maybe there's room to go up a size for that ET tube. And then pre-oxygenate for typically 5 minutes. They say that we're able to use less inhalant if we pre-oxygenate. And then oxygen is typically set to 2. If you turn it up higher and increase the oxygen and the ISO's on, they're going to get more ISO in. So then the patient's going to be deeper, so just be cautious of that. This is just a quick overview of pre-meds. So really what we're looking at when we're planning surgery, planning what meds to give, we want to target multiple different steps of the pain pathway. So really we're looking at a multimodal drug combination. So using like local anesthetics around the incision, lidocaine, blocks, especially when it comes to dentals. That's going to be one way to really target that initial kind of pain measure right at the level of the skin or the gums. And then IV pain medications, and then we use our inhalant. So looking at the anesthetic triad, so things that we target with the meds that we're reaching for. Usually we're using like an opioid and then a sedative on top of that. So we want narcosis, so loss of consciousness, and then the pain control, and then muscle relaxation. And then like your doctor will be calculating the drugs and dosages, but it's good to just have an idea of not only how they got that, but also the drugs that we only have so many drugs on hand. So if it's hydro and Dexmed and propofol, those are like the more common ones. We should have an idea of, you know, if we're doing surgery maybe every day or a couple times a week, like the dosages and the mils for that patient. Like if it's a smaller dog and there's a decimal off and it's 2 mils, but really it should be 0.2. It's good to have that checks and balance. Like this seems like a lot, and usually I don't give this much to a small dog. So just understanding how they got their calculations. So you're going to take the kilograms, and then you have the mg per kg, so that's going to cancel out, and I usually kind of spread it out like a train. It's just easier for my brain to understand that. So whatever is diagonal from each other is going to cross out. So you have the kilograms for the dog, and then the mg per kg, which is the dose, and it's whatever dose, there's usually a range, and then you have the concentration. So then it's 10. So for hydro, it's 10 mg per mil. So then that 10 is going to go on the bottom because it has to be diagonal. So then you multiply across the top, divide by the bottom, and that's how we get the final mil that we're going to administer. And then propofol, usually we'll kind of have an amount, and then it's best to really titrate that as needed. And then best case scenario is you have leftover in case they become light or you're moving the dog or cat and they start waking up, then you have that on hand. And then, so effects of different medications. So things to think about with the meds that you're using. So your ISO or your inhalant, that's going to decrease blood pressure and your respiratory rate. So really the best thing is that your induction meds and the meds that you're using are really appropriate enough, and they kind of are enough to keep the animal out, and then the ISO just helps a little bit. It's important to use the lowest amount possible of ISO, just because we see so many side effects of having to fight with the blood pressure and the heart rate and everything just kind of tanks when the ISO's high. So that's probably one of the most important things. Then we'll get into different depths of anesthesia. Opioids, those are going to decrease the heart rate. Hydro, that we could also see they become very panty and then drooling as a side effect. So those are things that if the dog came in and was happy and then you pre-meted it and it's just drooling and panting everywhere, it's probably the hydro. I wouldn't be too concerned. And then buprenorphine counteracts other opioids. So if it's something that sometimes we, especially in cats, if they were on oral buprenorphine and then we decide to do surgery and they had gotten it that morning and now we're doing surgery in the afternoon, you might be fighting a little bit during anesthesia, just because the kind of pure opioid, the like hydro, is going to not work as well. And then midazolam, those are probably the most common like sedative that we use. The only main risk is they can become paradoxical hyperexcitable, especially in young patients. So if we give it and then the dog just starts absolutely freaking out, it's probably the midazolam, and then usually we'll have to either just induce them really quickly and try to kind of fight over that, or give them something else to help sedate them. And then propofol, probably the most commonly used. Make sure you titrate it to effect, give it slowly to reduce the risk of apnea, because they could just stop breathing if you give it too fast. And then just always have that on hand or know where it is quickly in case the dog starts waking up and freaking out. Even as you're moving into recovery, it's good to just have that on hand. So then once the pet is down, looking at the depth of anesthesia is going to be really important. So is there spontaneous movement? That's really the most accurate indicator that they're not adequately anesthetized. So if they're spontaneously moving, then you want to get them at a deeper plane. Is there any reflex movement? So limb withdrawal if you're touching their toes, and then looking at muscle relaxation, usually jaw tone, and then their palpebral reflex, eye positioning. Those are really the most important things. I really like this chart. That's what I go off of in my head, just as far as if there's any situation where the dog may seem too deep, with like changes in the heart rate, the blood pressure is too low. Really the first thing that the doctor's going to ask is what depth are they, like how deep are they, can we increase the ISO, can we decrease the ISO. And when we're asking those questions, we're really thinking about kind of what the patient is doing and what they look like under. So is their jaw tone, where's their eye position at? If their jaw tone is very tight and their eyes are central and they're starting to move, dog's too light, you could increase the ISO if it's at like 0.5. And we'll get into kind of examples. If the ISO is at 3 and the dog's still light, then chances are we should just reach for other pain medications or sedatives because it's just not effective enough. And so a couple things to really pay attention to is looking at a light plane of anesthesia versus a deep plane. So both of them, their eye position is usually central. So just because the eye position is central doesn't mean that they're in a light plane. You also have to look at palpebral and then jaw tone. So if there's no palpebral, no jaw tone and the eyes are central, then they're probably too deep, usually accompanied by low blood pressure, heart rate, and everything. So try turning the ISO down. And if it's already low and they're deep, turn it off, or start reversing things if they're just very sensitive. But I'd say a majority of the time we're fighting with the light plane the eyes are central and they still have jaw tone. So in that case, try increasing the inhalant if your blood pressure will allow it. We'll kind of talk about that because that's kind of the biggest challenge of anesthesia is maintaining blood pressure, and it's the most important part of surgery. And then, if they're still light, just give additional medications. Meds last for a certain period of time, so especially if your surgery is going a bit long, then we may have to re-administer meds, or if it's a puppy and they're just fighting through it, it's an aggressive dog, then that's certainly okay. So then we'll get into just anesthesia monitoring, so just the different equipment that we use. We'll start with the end-tidal CO2, and then just go into some examples of the different waveforms. So CO2, so we use capnograph to measure the CO2 in inspired and expired gases. So normal is going to be between 35 and 45. Anything lower, so if you're hypocapnic, you're going to usually be hyperventilating, so that's going to be inverse. So if you kind of think about like if you hold your breath and that need to like breathe essentially is your CO2 building and you're becoming more acidic. So, and that's what happens if you're hypercapnic and you're essentially hypoventilating and just breathing really slow and holding those breaths, then that's kind of where we see the CO2 go up. So typically, if they're hyperventilating and their CO2 is low, then really the main thing is you could try to see if your cuff is leaking, if it became disconnected, if they're too hot, like they could start panting. If they're too light under anesthesia, then they could also start like panting just from being painful. So check their depth. That's always the number one, is really check their depth and see how much room we have to increase or decrease ISO. And then if your CO2 is too high, then they're hypoventilating. You could try to hyperventilate them and just give them a few quick breaths just to see if that will help first, and then see if they're just too deep under anesthesia. Try decreasing the inhalant, and just you could also see if they're rebreathing any CO2. That we could typically see if we're concerned for them rebreathing. Usually if there's the ET tube's too long and it's starting to build like condensation and there's a lot of extra dead space, we could see them starting to rebreathe CO2. So troubleshooting that, try to eliminate dead space, make sure that your soda lime is changed. Those are kind of other ways to troubleshoot if the CO2 is too high. So looking at the waveforms, this is normal. This is a perfect world. It's between 35 and 45, exactly at 40. Kind of best case scenario. These are just things to look at. If you're seeing your waveform start to look more like a shark fin, then we get concerned with, is there an obstruction? So condensation or a mucus plug forming in the ET tube. Sometimes if it's consistent, you may have to rechange the ET tube and just look at it and see and make sure that that's not the issue. If it's going the other way, then that would be more concerning for a leak. So making sure that your cuff is inflated, there's no leak around the ET tube, and sometimes if it's not tied in, it came out, or if it's just too small and maybe there was a leak or there wasn't a leak when you checked it and now there is, it's certainly okay to say, hey, I think I need to replace this ET tube or do a larger one, or I smell ISO, let me figure out what's going on. Like that's okay to say during anesthesia. Apnea. So usually if you just see the waves stop, just make sure the CO2 is hooked up. And then kind of best case scenario, it's like became unplugged and you just plug it back in. Or if you gave propofol too quickly, if the dog started waking up right when they started cutting, the dog started moving, you gave propofol really quickly, and then you're seeing this, just give it a couple minutes. And then the kind of gap from the bottom to the top before it gets to the normal waveform, that's just rebreathing. So that's in a dead space. Could be kind of what we talked about before. So is the ET tube too long and there's dead space? Has the absorbent been changed? Sometimes the valves on the anesthesia machine can stick. So just like hitting it or shaking it and unsticking those valves. And then are they hooked up to the rebreather versus non-rebreather, and is that appropriate for their size? And then things that you don't want to see, as far as obviously you don't want any cardiopulmonary arrest. So if you start to see your waves, and this is really the first thing that you'll see if a dog is about to code, is the CO2 waves start to change. So if you start to see kind of that step down, really just turn off everything and check the patient and see what's going on. Are they about to code? Kind of have drugs on hand and ready, obviously, let your doctor know. And then the cardiac oscillations, not concerning at all. That's just means that there's the CO2 monitor is picking up the heartbeat through so that's the heartbeat on the waveform. So that's completely normal. I feel like we use the vent a lot, and I feel like we usually see that more when they're on the ventilator. And then getting to blood pressure, which is probably the most important thing. So the blood pressure that we typically will use, we use the oscillometric. It's an indirect measurement of cardiac output. Blood pressure is important for everything. Wound healing, maintaining their body temperature, more important organ function. So blood flow going to the kidneys, the brain, the heart, you need blood pressure. So what we're looking at, systolic over diastolic, really the main number that we care about is the MAP, so the mean arterial pressure. We really want that to be above 60. If you're looking at the systolic, like if you're using a Doppler, we want it to be above 90. If it's low, they're hypotensive. If it's high, they're hypertensive. So different types of blood pressure monitoring. So you either have direct, which is used more in like critical care settings. So placing an arterial blood line, that's really the gold standard, but they're extremely difficult to place, and they're just usually just used in more critical dogs. So we settle for the indirect, either a Doppler or the oscillometric. When we have the cuff, it's important to use the appropriate cuff based off of the pet's limb circumference. So dogs, it should be about 40% of the circumference, and then cats, it's about 30 to 40%. So if you're using a cuff that's too small, it can be falsely elevated, the blood pressure, and if it's too large, it could be falsely low. If for any reason you are not just struggling with the blood pressure, or you don't believe it, you could always just check femoral or pedal pulse. If they have a femoral pulse, it's going to be at least 60. So that's just something to kind of check yourself if you're concerned, especially if it's a dog that's like even just sedated and not really hooked up to a full anesthesia monitoring, and they got decks for x-rays and you're reversing them and you're concerned for blood pressure, just check femoral pulse and just make sure that's there. If that's not there, then we get more concerned for having to troubleshoot why the blood pressure is very low. So fighting with hypotension, really the main causes, so hypovolemia, that's usually what will at least start troubleshooting hypotension as, is if they're hypovolemic, even if it's a puppy or a kitten that's really young, and they seem hydrated, maybe they can benefit from a fluid bolus to try to get some extra fluid in their vessels. So usually we'll start with, if they're hypotensive, looking at the depth. Can we decrease the inhalant? That's first thing. If we're able to, then great, give it a couple minutes, see if the blood pressure improves. If we're still fighting with blood pressure, usually we'll start by giving a bolus, like a 5 to 10 ml per kg bolus. Like, usually they don't need blood products, but if it's a hemoabdomen that you guys are cutting, then they may need blood products. But usually we just get away with giving some fluid boluses and hoping that raises the blood pressure enough. And then usually the blood pressure will go with the heart rate. So is it too slow? Are they too deep? So always checking the ISO, and if we're able to turn that down. And then different drugs. So Dexmed, we'll see decreased heart rate, and then their blood pressure will decrease, and then same with propofol and ACE. So really the most commonly used meds are going to cause hypotension. So it's usually fighting with that and hopefully getting away with some fluid boluses. If they're hypotensive and bradycardic and they got Dexmed, and it's like right at the beginning of surgery, then we could consider reversing the Dex and seeing if that helps. If they're hypotensive and bradycardic, say we reverse the Dex and it still hasn't improved, the ISO's down as much as it can be, then we may consider reaching for the anticholinergic drugs like atropine or glyco. Atropine is going to work faster. Glyco is going to be a slower onset, but it usually lasts a little bit longer. But you could really only give those if once you reverse the Dex. If the Dex is still on board, don't give any like atropine. And then if they're hypertensive, they're probably just painful. I feel like they're never really hypertensive. But if they are, then they're probably just trying to jump off the table from surgical stimulation. So increase the ISO, check your depth, see if they're painful. We could always give more pain meds. And then looking at ECG. So ECG, indirect measure of electrical impulses for the heart rate and rhythm. So your leads, usually we don't use green too much. We don't really use green, but white is going to go on the right side, and then you have on the left side, it's going to be black on the front, and then the red on the back left. So usually it'll go like smoke above fire, and then snow above grass. So then the green is going to go on the right hind if you have green. And then wet with alcohol, or you could use like ultrasound gel. Keep in mind that if it's a long anesthesia, that if you're having any issues with the ECG reading, like right in the middle, then the leads may have become dry. So just try like re-wetting them. And then again, ISO and different meds are going to cause bradycardia. And then think about the heart rate of that patient. So, it's not the same for every animal. Younger, like puppies, their heart rate's going to be higher even under anesthesia. Smaller dogs, it'll be higher than larger dogs. And then cats, it's going to be higher than dogs, even under anesthesia. So those are just things to think about. Looking at a normal ECG, so you have the P wave, and then the QRS and the T wave. And those mean kind of different functions of the heart chambers and kind of release of blood. So the most common, I'll talk about really the two most common arrhythmias that we'll see. So type 2 AV block, we see that probably the most common under anesthesia if they got Dexmed. you could try to reverse it. Usually it'll be secondary to that, secondary to anesthesia, and just being bradycardic. So trying to play around with the heart rate and get a higher heart rate, again, lowering your ISO and seeing if once their heart rate comes up, if that has resolved. If it's pretty consistent and it's getting worse, then we may consider giving atropine, which we'll get into, just to help increase the heart rate. And usually once the heart rate's improved, then that should resolve. And then the other more common arrhythmia, I'd say usually we see this in dogs that are more unstable, but it can certainly happen in any dog. So VPCs, ventricular premature complexes, so you're just cruising along through anesthesia and you have normal rhythm, everything's going great, and then randomly you see this like mess of a wave. That would be just a premature complex that happened. So the ventricle just decided to kind of squeeze and release blood in the middle of a normal heartbeat. So those, if it happens occasionally, like, it's good to note and it's good to make everybody aware of it. But usually if there's maybe one or two every once in a while, we'll let it go and try to, again, decrease the heart rate or decrease the ISO to try to increase the heart rate, see if that helps. Try to lower the ISO and give, and see if we could get them at a lighter depth. If we're starting to see runs of those where that's really all you see, there's no normal waves and it's just those VPCs constantly, then that's when we'll usually reach for like an antiarrhythmic medication like lidocaine. Usually we'll just try to turn ISO off and try to get the patient up as quick as possible, and then have them follow up with cardiology. So really troubleshooting heart rate, you compare it to the pulse ox. The pulse ox is frowned upon sometimes, but if you don't believe the pulse ox because it's not reading and it's acting up, which it usually is, then just check your leads, make sure they didn't become dry. Usually it's set to lead 2, so make sure that didn't get changed, and then just confirm with the stethoscope, and see if it really is 25. If they are bradycardic, with or without arrhythmias, it really depends on the patient. So a lot of times we'll have a large dog that their heart rate's like 30 to 35, which is lower than we'd want it to be under anesthesia, but their blood pressure is fantastic. Like MAP is 90 and they're doing great. There's no arrhythmias. We may just let it go. If it's a smaller dog, we get more concerned. So it really depends on the patient itself. If there's any arrhythmias, that's when we start really reaching for meds to try to increase the heart rate. And then when in doubt, if they got DEX, you could always reverse that. Just keep in mind that when you're reversing medications, those meds are doing something. They're providing a pain control, a sedative, a muscle relaxer. So if you're reversing that, you're taking all of that away. So they may become light quickly. They may try to jump off the table. You may have to supplement a different type of sedative like midazolam if you're reversing that. So those are things to keep in mind. And then I'll just touch upon pulse ox because use it. It's a measure of the oxygen saturation. So if it's not reading, just look at the patient. Like if it says that the pulse ox is 60 but the gums are pink, it's probably not right. And then if they are truly purple, then that's probably right. So definitely figure out why they're purple. Troubleshooting, which I feel like is probably the main thing you do with pulse ox. Ensure the sensor's on, re-wet it, so you could try to put like a damp gauze between the sensor, like around the tongue. And then just keep adjusting the location. The tongue, you could try the ear, the paw pads, and then the prepuce or the vulva. And then by the time you get 100 on pulse ox, the surgery will be over. So post-op care, so after surgery and we made it through that, recover the patient in a quiet environment, and then usually we'll go, our rule is like 3 really good swallows, to make sure that they have an appropriate swallow reflex, just in case they vomit or regurge. So keep them intubated, and sometimes it takes a long time, and you just sit there and try to be patient, and you could gently try to stimulate them, gently shaking or cleaning their ears, trimming their nails. Brachycephalic dogs, you want to keep them intubated until they are like walking around with the tube in, just because there's such a high risk of regurg and aspiration pneumonia. And then small patients, or if they're really young, we know that they were fasted in the morning. If they're just taking a really long time to wake up, check their blood glucose and see if that's low. They may need a little bit of dextrose just to help them become a little bit more alert. And then if they're just still absolutely out of it, you could try reversing meds, midazolam, especially if it's a really quick procedure. Like if it was a really quick mass removal, they got midazolam and it maybe took like 20 or 30 minutes, that's going to stay on board for like 1 to 2 hours. You could just try reversing that and see if that helps. Dex, of course, you could try reversing that. That's going to be IM reversal. And then your opioids, which is probably the most rewarding reversal, because once you give naloxone, I feel like they just like jump up and they're like ready to go home. The main downside of that is they just had surgery and you're reversing their pain med. So if they become uncomfortable, that's where like local anesthesia, like lidocaine around the area should help for a couple hours. But you can also consider like Torb. So Torb, you can it reverses more of the sedative, but it also maintains the pain control aspect of things instead of naloxone. So it's always something to consider. And then these are just different examples that we kind of encounter most commonly when a patient's under anesthesia. So their heart rate's low, the blood pressure's low, and their ISO's at 2, which I'd say is a little bit high. Like ideally it should be like 0.5 to 1. Really, you never really go up to all the way up to 5 unless like if the patient's starting to wake up and like jumping off the table right when they start cutting. Turn the ISO up, give a couple breaths, give some propofol, get them back down, and then after all of that, then we can see do they need more pain meds, and we'll start lowering the ISO back down. But if the heart rate's low, the blood pressure is low, because we want that would be the MAP. We want that above 60, no matter what. The most important thing besides making sure they don't have arrhythmias is making sure your MAP is at least 60. So look at the depth. Are they too deep? Can you lower the ISO? Which an ISO at 2, try lowering it by 0.5 each time you go down, just to make sure that they don't go from 2 to 1 and then they're too light now, and trying to jump off the table. So lower it by like even 0.25 or 0.5 increments, just to see if we could slowly start to get that blood pressure back up. And then the heart rate's high, so like about 140 blood pressure is good, so it'd be fine with a MAP of 70. Your ISO's 2. Are they painful? So blood pressure's fine, but heart rate's high, especially if, and usually they'll, your doctor will tell you when they start cutting. So make sure that you're really checking that heart rate right when that first incision's happening, just to see if did it go from 100 up to 140 at that moment, because they may be painful. So you consider adding additional pain meds, because with your ISO, like, of course, still check your depth, but if you're having to go up on ISO from 2 to like 2.5 or 3, like ISO really doesn't need to be that high. Especially then once you're moved into like recovery, I feel like it's going to take the patients longer to recover. So you want them at like a light to medium depth, especially usually they'll be around a medium depth. So eyes are going to be more rolled back, no jaw tone. That would be ideal during surgery, and then when they're starting to close their the skin, start lowering that ISO and lowering the meds. This way we get them into a light plane, so when they're moved into recovery, they recover a bit quicker. Looking at heart rate's high, blood pressure's high, but your ISO's at 0.5. They're probably just too light. So try increasing the ISO first, seeing if that improves things. Once they settle into anesthesia, if ISO's like 1 to 1.5, the heart rate, the blood pressure starts to come down a bit. They're more comfortable. If there's no improvement, then they may just be painful, and then you could try adding pain meds. But I would start with the ISO first. And then looking at heart rate and blood pressure low, your ISO's at a pretty good setting, but of course check their depth, see what you could do. You could either try to turn the ISO down if maybe they're too deep and they're just sensitive to ISO, or their pre-meds hit them really hard. Try to turn the ISO down to like 0.75, 0.5, seeing if that improves things. If not, then try maybe reversing the Dexmed and seeing if that helps. But keep in mind that they may need alternative pain meds or sedatives. And then that is it. Questions? You know, it's like a lot too. It's a little bit of everything. But I could always send the PowerPoint. This way you could have kind of a way to reference things, especially if really like just the plane of anesthesia. It's what I learned off of and what I always have in my head when any questions asked. So I feel like that's the most important thing.
Is that something that you can send to Dr. Cooper SLS for us?
Yeah.
And if we need to, like, I know like in general, like having like paper forms and stuff, we can always like cut that out and print and laminate it for you guys too, and do that sort of stuff.
Yeah.